Okay, so this is a 55-year-old with severe triple vessel disease, normal LV, unstable angina, class 3 for the last 6 months. This is his angiogram. LV is normal, right is occluded, and it's filling the left side. Distal LED is filling, as you can see, quite well from an epicardial collateral. It's a large collateral, and it's you can see that it's filling end to end, right up to the apical part or the mid to distal junction. The left system, there is a large area of being served by a large OM which is severely diseased. As you can see, OM is severely diseased, and the PLV and PDA is filling from this side. You can see the PDA and the PLV both filling from this side, and the LED is occluded in the mid part. So this is the case. The discussion is essentially for the cabbage. She is a cabbage refusal. If you can look at the LED, the left main is also mildly diseased, and so he's an arteriopath, non-smoker, non-diabetic, strong family history. So how to proceed in this case if he's not going for cabbage? So this is the case today. Total versus near total versus partial revascularization. So this is his angioplasty here. So we started with the right, subtotal here. We had quite a lot of difficulty in trying to wire. The wire, this is the Fielder XT, it wouldn't just go, it would not cross. With great difficulty we managed to put it across the PLV, and then we did a lot of ballooning, and finally we did a 2mm balloon, and you could see that something is coming out, and the wire has looped. It's useless now. The PLV is filling, and there seems to be a calcified plaque there. So we opened up the PLV. It's a large vessel, collateralized, and after a lot of ballooning and persistence, we managed to get both of these vessels. So we decided, now the decision was, after looking at all this, the decision was not to compromise either of these two vessels, so wanted to put a stent at the junction. So the stent went in, and then after that we managed to recross into the PDA, did a kissing balloon inflation, and managed. So this is the final result, and you can see that the stents here, tortuous vessel, the PLV is filling, as is the LED. So I think a acceptable result here, and so this is the first part, and you can also see that the distal LED is filling here. And by the way, this patient had ischemia on thallium in the infrolateral inferior and infrolateral basal, mid and apical, inferior and infrolateral part. So this is basically left circumflex and inferior territory. So then we proceeded on to fix this, put in 2 wires. This is relatively simple, and so just quickly stent with a JKST method, or just keeping the mouth open, not going across, and finally the results quite acceptable. You can see that this artery is open, as well as there's a small dissection, but this is nothing to worry about. So this is that. Now the LED. The LED is, so went with a special wire, managed to cross the occlusion site here, and the wire would go into the diagonal. So we thought, let's open the diagonal and see how do we. So this is a very long diagonal. It's all the way down here from there. This was the occlusion site somewhere around here. So in order to do this, we decided for near total revascularization, because the LED would be here and the distal LED is very well filling from the right coronary. So this is anterolateral part. This diagonal was not filling and it's a long one. So we decided to stent this, and after stenting and optimization, you can see, so this is what we got. We've stented the LED mid part towards the diagonal. The rest of the LED comes off here and it's filling from the right side. So I think this is near total revascularization rather than total revascularization, but I think most of you will agree that this is a significant diagonal, and opening the LED would have compromised this. So, and this is the final result here. The left main's got a little bit of plaquing, but I think that can be left for another time.